understanding and interpreting different ECG or EKG strips is one of the core areas which the NCLEX exam tries to test your knowledge on. This one topic is so important that even practicing nurses in ICU and critical care and different wards frequently come to me for notes and learning the heart waves and interpreting the ECG or EKG waves and diagnosing different conditions. It is very important for your nursing practice even after you pass NCLEX. Again, I request you this is a very, very important lecture. So, along with the theory, I will be explaining things with many practical explanations, quizzes, and case studies in an NCLEX format so that you can overview the real exam-based scenario when going through these questions. I will try to make it as simple as possible so that you can memorize things quickly for your exam preparation. So make sure to hit that like button, share this video with your classmates and fellow nursing students, and don't forget to subscribe to our channel to stay updated on all our latest videos. Without much delay, let's start on today's topic. As a registered nurse, we should be able to read and analyze the heart rhythm and cardiac abnormalities, which could be heart block, cardiomyopathy, pericarditis, or any heart diseases. For this purpose, we need some diagnostic tools. So, EKG or ECG, however, you may call it, are the diagnostic tools to analyze these abnormalities to look and interpret the heart rate and rhythm. Note that EKG or ECG, which are interchangeably used, are also called electrocardiograms. We will refresh our knowledge in brief about cardiac conduction so that you know the origins of the wave you see in the ECG and the components of the heart wave. This figure that you see here is a normal heart wave. You see different marked peaks and depression and gaps in between these things. Based on their occurrence, position, and gaps, we will interpret all the major cardiac conditions with the simulated examples. So, that's for the first topic. After this, we will learn the basics of heart rate and how we can measure the heart rate with the EKG strip and interpret some basic things. After this, we will walk through the heart rhythm and learn and interpret the normal sinus rhythm. Remember, sinus rhythm is a basic rhythm that a normal person shows. After we have gained some traction in the rate and rhythm, we will be ready to understand the strips and interpret the ECG. We will interpret the normal sinus, bradycardia, and tachycardia. Note that we are talking about ventricular rate and rhythm when we are talking about normal sinus, bradycardia, and tachycardia. What about rate and rhythm happening in atria? For that we will study supraventricular tachycardia. We will also study about atrial fibrillation, atrial flutter, and ventricular fibrillation, and study in depth with practice examples on different types of heart blocks. After this, we will also study about myocardial infraction and asystole. So, altogether, this is going to be a really fun, engaging, and very, very important for the nursing school exam, NCLEX exam, and also a revision tool when you are practicing as a registered nurse after your nursing school and exams. And let me make you calm, because this is going to be easier than what students think about interpretation difficulty. There will be plenty of explanations in easy language and examples, and I will try to make it look and feel as easy and memorable as possible. Good luck for your journey ahead. Before going through the interpretation and NCLEX practice question session, let us understand how the conduction of the heart or electrical conduction in the heart works. Any problem with a heart condition is a result of change in these conduction waves. We know well that a heart consists of 4 chambers: right atrium, right ventricle, left atrium, and left ventricle. On the first compartment, or right atrium, you can observe a node, also called sinoatrial node. This is important as the impulse conduction starts at this place. This is also called the natural pacemaker. Next, somewhere in between the right atrium and right ventricle, there is a V node, which is also called gatekeeper, as it receives signals from SA nodes. The SA node is also called the natural pacemaker of the heart because it is where the signal from SA node is transferred to the ventricle to contract. When the signal reaches the V node, it branches out to bundle of His and then to right and left bundle branches and reaches the conduction branch near the apex of the heart, also called Purkinje fibers. Note that there are definite ranges of the conduction system of the heart depending on the origin of these impulses, which are known as intrinsic rates. So, as we discussed earlier, in a normal condition, the impulse starts from SA nodes to a V nodes reaches down to the Purkinje fibers. This causes heart to expand and contract at definite intervals. The SA node generates the electrical impulse at 60 to 100 impulse per minute, so the intrinsic rate for SA node is 60 to 100 BPM or beats per minute. If for any reason the SA node is unable to generate this conduction rate, no impulse can transfer to a V node, but still the V node can generate impulse at 40 to 60 BPM. This is one of the reasons why heart blocks have slower rate than the normal rhythm of 60 to 100 beats per minute. What if the AV also cannot generate or fails to meet the intrinsic rate required for survival? We learned that if SA node fails to conduct, a V bundle still works. If the AV node also is not able to generate an electrical impulse, then the bundle branches will generate their own impulse. The bundle branches generate electrical impulses at 20 to 40 beats per minute, which is regarded by physicians as complete heart block or third-degree heart block, and this is an emergency situation in ECG interpretation. Look at this figure. We can see different waves such as P wave first, then this wave with long amplitude called QRS complex, and then a wave at the rightmost part called T wave. The P wave, QRS complex, and T wave together forms one complete cardiac cycle. So, what are the origins of these waves and what do they represent? P wave. When the SA node first starts the conduction of impulse, it is called atrial depolarization, and this is represented by P wave. During this time, both the left and right atria contact, and this squeezes blood to the ventricle. QRS complex. When the AV node starts firing the electrical impulse, it represents the ventricular depolarization, represented by this QRS complex having a high amplitude. During this period, the right and left ventricles contract to squeeze blood to the lungs through the artery. T wave. All right. So far, the atria has contracted, ventricle has contracted, and now is the period of relaxation. This relaxation period of a V node, bundle of His and Purkinje fiber or relaxation is represented by T wave, and during this period, ventricles are refilled with the blood. As the atrial and ventricular relaxation takes place at the same time, and also as the electrical impulse of the ventricles is powerful enough to mask the small wave that would represent atrial repolarization, we cannot identify the wave for atrial repolarizations. So, let's revise in short what we learnt so far. P wave is for atrial depolarization, and there is atrial contraction to send blood to ventricle during this period. QRS complex represents ventricular depolarization, and in this period, ventricle contracts and atria relaxes. T wave represents the ventricular repolarization, and in this period, the ventricles simply relax. ECG interpretation basics. We learned in the previous units about heart nodes, intrinsic rates of firing from these nodes and cardiac cycle made by the P wave, QRS complex, and the T wave. We are now ready for the basic interpretation of ECG, but before that let's learn further about intervals and segments in the ECG wave. So what is an interval? It is the time duration between these points in the cardiac cycle diagram. A segment, on the other hand, is the time duration between these two waves. Let's discuss what each interval and segment means in relation to what's happening in the electrical system of the heart. PR interval. The figure given here shows the PR interval, and this is the time for electrical conduction from SA to a V node. PR segment. The segment just before the QRS complex is the PR segment and represents completion of atrial depolarization. QT interval represents all the electrical ventricular activity. ST segment. This represents completion of ventricular depolarization, where all electrical activity falls onto the isoelectric line. And this is the segment just before the T wave, or ventricular repolarization. Let us now learn about understanding how to read and interpret using ECG tracing paper. We are talking about time, but the printed ECG paper can only measure the length. Don't worry, the ECG paper is designed to observe two things. First, horizontally, if we measure from left to right, we can measure the time. For example, here in this figure, one small box represents 0.04 seconds and a big box represents 0.2 seconds. If we observe vertically from top to bottom, it represents the conduction amplitude or firing in millivolts. Now we are ready to interpret the EKG or ECG paper looking at these wave patterns. For interpretation of the ECG, you have to analyze 5 most important things process-wise. Let's start with the first process of this task, that is to determine the heart rate. We studied earlier that the atrial depolarization represents the heartbeats and number of impulses produced and transferred to the AV node. The atrial depolarization represented by the P wave can be counted to find the number of atrial beats or number of heartbeats. For ventricular rate count, we have to count the total number QRS complexes, which represents total ventricular depolarization periods. How did we do that in an ECG or EKG strip? I'll teach you the 2 methods that you should know for your NCLEX practice. First is the 6 seconds method and second the rate determination method. The 6-second method. In this method, you have to see a 6-second interval in the EKG strip, see the total number of QRS complexes. We know that when the ventricle contracts, a heartbeat is felt, so 1 QRS complex corresponds to 1 heartbeat. So after counting total number of QRS complexes inside the 6 seconds mark, we have to multiply that number by 10, which represents total number of heartbeat in 60 seconds or 1 minute. The following EKG shows a regular rhythm with upright and uniform P waves with PR interval of 0.12 to 0.20 seconds. What is the heart rate? We see 7 QRS complexes in 6 seconds. Our job is to multiply it by 10. Therefore, we have 7 times 10 equals 70 beats per minute. Next is by using the EKG rate determination chart, and this is the more preferred method for heart rate determination. You just have to count the number of small spaces between 2 R peaks and then correlate that number with the rate determination chart. For example, suppose if the number of small spaces between these 2 peaks is 21. Then correlating number 21 with the chart shows total beat as 71. Okay, so now we have determined the heart rate. The next step is determining the heart rhythm and seeing if the pulses are showing regular or irregular pattern. To find if the pattern is regular or irregular, we just have to see if the interval between 2 R waves are irregular or not. How to do that? For accessing the rhythm, we measure the small boxes from R to R if 2 interval vary by less than 0.06 seconds or 1.5 small boxes. We say the rhythm is regular or else the rhythm is irregular. Generally, in exam conditions, you won't be asked to count the boxes, but may be asked if you know to determine regular rhythm or not. Quiz time. Can you observe what is wrong with the rhythm from the ECG wave? Yes, you are right. The spaces between the R waves vary. The rhythm is irregular. The third step is analyzing the P wave. The P wave should be present in every cardiac cycle. We have to see if the P wave is occurring regularly. If P wave is not presented regularly or absent in some cardiac cycle, there could be problems with S and node, right? But we need to further investigate this on more to find out the real problem. The fourth step is measuring the PR interval. So we already learned that the PR interval is the time between atria and ventricular contraction onset. It is the interval between P wave onset to QRS wave onset. If the PR interval is long, the heart rate is slow as it is taking longer time for impulse to travel from S a node to a V node. The normal PR interval should be 0.12 to 0.20 seconds that corresponds to 3 to 5 small boxes in EKG strips. Basically, what you are measuring is how long it takes, in time, for the electrical impulse to travel from the S a node to the V node within the conduction system of the heart. It is important to understand that the longer the time, the slower the heart rate. Also, you need to see if the PR interval is consistent or not. If it is not consistent, this may be the indication of second-degree type 1 heart block. We learned that the normal PR interval should be greater than 0.2 and less than 0.12 seconds. So what message can we gain from this interpretation? If it is greater than 0.2 seconds, the conduction of impulse is taking a long time, and probably this represents the heart block. If it is less than 0.12 seconds, the heart is beating too fast and this denotes tachycardia. The small boxes counting in the EKG strip showed the following reading of PR interval for 6 strips. Can you interpret the possible problem? Here, the box's width seem consistent. But we also learned that normally, for sinus rhythm, the PR interval should be between 3 to 5 boxes. One small box equals 0.04 seconds. So 6 boxes equals 0.24 seconds. The PR interval, though constant and consistent, are greater than 0.2 seconds. The conduction of impulse is taking a long time, and probably this represents the heart block. All right. We saw the heart rate and rhythm, watched out for P wave, PR segment. The final step is measuring the QRS complex. Look at this figure. It shows the length of QRS complex interval. We learned earlier that QRS complex represents the contraction of ventricles or depolarization. The normal QRS complex interval is 0.06 to 0.12 seconds, which corresponds to 1.5 to 3 small boxes. If the QRS complex interval is lesser than 0.06 seconds, it denotes tachycardia. If the QRS complex interval is greater than 0.12 seconds, it denotes it may be due to some disease such as damage to the HIS Purkinje fibers. The next chapter with interpretation will be important after learning all these interpretations and covers many case studies. Normal sinus. So what is a normal sinus? A healthy adult shows normal sinus rhythm. It is a regular rhythm. The rate for normal sinus rhythm is 60 to 100 beats per minute. We have discussed about the cardiac cycle before too. The normal sinus rhythm looks something like this with normal R wave QRS complex and T wave. But how to access a normal sinus rhythm? The duration interval for P wave, which is before QRS complex for normal sinus rhythm, is 0.12 to 0.20 seconds. QRS width interval is 0.04 to 0.12 seconds. QT interval is less than 0.4 seconds. Okay, so much with the theory. Let's look at a quick question for practice. For this, let's run the quiz. I will give you 10 seconds to go through the options and select the correct answer. If you need more time, you can also pause the video. A registered nurse at Critical Care Division is assessing an electrocardiogram rhythm strip. She observes the following reading. What can she infer from these readings? Your options are, this is a normal sinus rhythm. There is a problem with rhythmic contraction of ventricles. The PR interval is not normal. The QRS interval is not within the requirement for normal sinus rhythm. As I told earlier, you can pause the video now. All right. I hope you got the answer right. The first option is correct answer here. The conditions for normal sinus rhythm are P width before each QRS should be between 0.12 to 0.20 seconds. QRS interval is 0.04 to 0.12 seconds. QT interval should be less than 0.4 seconds. Since all the parameters given obeys all the acceptance criteria for normal sinus rhythm, it is a normal sinus rhythm. All right. Good job if you got that right. Let us go to the second question. Can you identify the criteria for which the following diagram doesn't obey the normal sinus rhythm from this ECG strip? The waves interval are not regular. The amplitude of the wave varies. The QRS interval is out of shape. The P wave is missing at some places. Your time starts now. All right, let me reveal the answer. The correct answer to this question is the intervals are not regular. This is quite obvious from the diagram too. Next, we will go through the interpretation of sinus bradycardia with examples and practice quizzes. sinus bradycardia. By now you know the criteria for normal sinus rhythm. The term bradycardia means heart is beating slower than the normal rate. That means less than 60 beats per minute. So how can we identify sinus bradycardia? We have to see if the P wave width or intensity is between 0.12 to 0.2 seconds or not. QRS width should be between 0.04 to 0.12 seconds. QT width should be less than 0.4 seconds. We talked that sinus bradycardia has rate less than 60 beats per minute, but sometimes even the healthy athlete can have less than 60 beats per minute, but is still considered normal. There is a problem only if the patient shows any symptoms such as shortness of breath, dizziness, syncope, problems with blood pressure, etc., along with the mentioned rates of bradycardia that we talked before. The patient on certain drugs such as digoxin should also be given proper care because it can cause bradycardia. So what should be a nurse's response for sinus bradycardia? She should first access the patient, and then if the bradycardia is symptomatic, she should prepare for transcutaneous pacing and give atropine. All right, let's start our quiz session. A client is complaining of dizziness and has shortness of breath. She shows heart rate of 42 beats per minute, and upon observation of the BP, it is clear that she has a hypotension with a reading of 85 and 55. Which of the following could be the causes of this problem? Her blood glucose level of 100. She is prescribed atropine. She could be suffering from some viral fever. She is prescribed digoxin. I will give you some time to look for the answer to this problem too. All right, let me reveal the answer to you. The correct answer to this question is the last option, that is, she is prescribed with digoxin. We learned that certain drugs such as digoxin causes bradycardia, and these all symptoms that she is showing such as dizziness, shortness of breath, and hypotension are the symptoms of bradycardia. Next question for your practice. A patient is feeling weak, lethargic, and dizzy. Look at the following ECG strip reading. What problem can you identify with this reading? PR interval is 0.18 seconds. QRS interval is 0.06 seconds. QT interval is 0.2 seconds. Heart rate is 50 BPM. BP is 80/60. Your options are, she has a normal sinus but low pressure. Second option. She has bradycardia. Third. She has tachycardia. And the last one. She could have some heart blockade. Take your own time to answer this question. All right, let me reveal the answer to you. The correct answer to this question is she has bradycardia. She shows the symptoms of bradycardia, and her vital ECG details also matches to that of bradycardia. In this unit, we are studying about supraventricular tachycardia. First of all, let's talk about identifying supraventricular tachycardia. The origin of impulse for this type of cardiac disorder is not as a node, but a V node, and usually above the bundle branches and ventricular tissue. It presents extremely fast atrial rhythm and narrow QRS complexes. They have normal P wave, but usually not clear as they are masked by preceding T wave and PR intervals. Usually the heartbeat is so fast that it can go up to 220 plus per minute, and also there can be sudden decrease back to normal. The treatment should be rapid. As a registered nurse, you should understand that the patient must be treated quickly before they become symptomatic. The symptoms involve rapid dropping of blood pressure, shortness of breath, and may even involve fainting and convulsions. The patient should be given adenosine as a rapid management approach. For further practice, let's walk in through our usual section. Let's run the quiz. The nurse notices some symptoms of supraventricular tachycardia, such as sudden drop in BP to the level of 65 to 40 and feeling dizziness with a heart rate of 220 beats per minute. What should the nurse do as a management approach? Your options are administer beta blocker, administer atropine, administer epinephrine, administer adenosine, Your time starts. Options 1 is incorrect, as beta blockers can further decrease the blood pressure. The patient is already suffering from hypotension. Second option, atropine, is also not correct, as it can increase the heart rate. The heart rate is already very high and may lead to heart failure. Option 3, that is epinephrine, is also out of box, as there is no use of it and it further increased the heart rate. The last option, that is administration of adenosine, is correct one. Adenosine is given in rapid intravenous bolus injection into a vein or into an IV line. When given as a rapid IV bolus, adenosine slows cardiac conduction, particularly affecting conduction through the AV node. With this, we have covered this topic too. Remember to watch out for too frequent QRS complexes with P wave completely absent or masked by T waves in the EKG strip to identify the supraventricular tachycardia with underlying symptoms such as very high heart rate and low BP and dizziness in patients. The next topic is atrial fibrillation. Atrial fibrillation and flutter are topics of choice in many competitive examination. Atrial fibrillation is a very common atrial arrhythmia. The identifiers of atrial fibrillation are: P wave are not noticeable. The P waves are not identifiable, that means the SA node is not conducting the electrical impulses properly. The atria is not contracting well. Initially, this may not be a problem, but if atrial fibrillation continues over a time, as the blood hurls around the atria, there is possibility of development of blood clot, and as a result may result into dangerous conditions like heart attacks and embolisms. The heartbeat rhythm is irregular and frequent. QRS complexes are narrow. Please see this EKG strip given here. As we see, the P wave is absent, the rhythm is irregular and frequent, and this is an example of atrial fibrillation. The symptoms are similar to supraventricular tachycardia, such as tachycardia, shortness of breath, fainting, etc. As a nursing management for atrial fibrillation, see if the patient is concomitantly given any anticoagulants already. Also, if needed for symptomatic atrial fibrillation, prepare for cardioversion and give calcium channel blocker or beta blocker. All right, let's head into our usual section. Let's run the quiz. Which of the following EKG strip shows the atrial fibrillation? The first strip is for normal sinus. The second for sinus tachycardia. The third is for supraventricular tachycardia, and the correct answer is the last option. We know that supraventricular tachycardia has normal rhythm and supraventricular tachycardia shows frequent QRS complex. So you won't see much any other waves in between these QRS complex in supraventricular tachycardia. Let's now go to the second section. Question: in which of the following conditions is the P wave absent? The options are: first, tachycardia, atrial fibrillation, bradycardia, atrial flutter. The correct answer to this question is atrial fibrillation. Options tachycardia and bradycardia are not correct, nor is atrial flutter. In atrial flutter, in fact, we see multiple P waves in between each QRS complex. With this, we have ended this topic here. The next topic is on atrial flutter, which is another important topic in this section, and we will study it with some practical studies. Thank you so much for staying with me throughout this lecture. Let us see another ECG pattern. The atrial flutter, it shows the following characteristics: extremely high heart rate between 250 to 350 beats per minute. The rate is regular. The P waves are well defined and shows a sawtooth pattern. There can be single to as many as 6 sawtooth wave in atrial flutter. QRS is less than 0.12 seconds. One main characteristics is sawtooth flutter appearance in ECG showing multiple P waves for each QRS complex. The symptoms of atrial flutter are tachycardia, low BP, breathing shortness, fainting and palpitations, etc. As a nursing management, you should call for a rapid response in such condition, give calcium channel blocker or beta blocker, and prepare for cardioversion. The main differences between atrial fibrillation and atrial flutter are: during atrial flutter, unlike in atrial fibrillation, there is coordinated electrical activity. Thus, the atria do contract, but at a very rapid rate, which is about 250 to 350 times per minute. Also, if you see the EKG strip, you can observe a clear sawtooth pattern P waves, which is absent or blunt in atrial fibrillation. Which of the conditions can you infer from the following EKG strips? First strip for you. What can you infer from this diagram? This is an atrial fibrillation. As we see, the P wave is absent. The rhythm is irregular and frequent in atrial fibrillation. You should see multiple small blunt waves, and also, as we discussed, these wave patterns are very irregular. This could be normal sinus. There is normal P wave, QRS complex, and T wave. Also, we are given normal heart rate of 75 bpm, which is between the resting heart rate of 60 to 100 bpm. This is a systole. There is not any electrical activity or any wave patterns in EKG strip. This is atrial flutter. As we discussed, this can be identified with identifiers such as extremely high heart rate. The rate is regular. The P waves are well defined and shows a sawtooth pattern. Well, we have discussed a lot of things with these diagrams. You are doing a great job and a good progress. Keep it on. Heart is also made up of muscles. It needs oxygen and blood supply. When it is blocked, it cannot work properly. Heart is also made up of muscles. It needs oxygen and blood supply. When it is blocked, it cannot work properly. Pressure or tightness in the chest. Sweating, nausea. Vomiting. Intense pain in the chest, back, jaw, and other areas of the upper body that lasts more than a few minutes or that goes away and comes back. Shortness of breath, anxiety. Feeling like you're going to faint. ECG interpretation. There is a regular heart rhythm of around 80 beats per minute. The QRS is normal and the P wave is normal. One of the most difficult interpretation of ECG is for myocardial infarction. Let me present the most important identifying parameter for this condition. This line you see here called isolectic line. One of the most significant findings of myocardial infarction is the presence of ST segment elevation from the isolectic line. The ST segment is the part of the ECG tracing that starts at the end of the S wave and ends at the beginning of the T wave. Additionally, myocardial infarction show the following identifying parameter. In the first hours and days after the onset of a myocardial infarction, several changes can be observed on the ECG. First, large peaked T waves or hyperacute T waves, then ST elevation, then negative T waves, and finally pathologic Q waves develop. For early detection of MI, we observe if there is abnormal ECG pattern, that is deeply inverted T waves in leads V2 and V3, which is also called Wellens syndrome in myocardial infarction. You also see blood levels of cardiac enzymes such as CKMB or troponin T, which is a better diagnostic tool. We provide morphine to the patients with myocardial infarction as it decreases the myocardial oxygen demand. We know that patients with MI have low oxygen supply, so providing supplemental oxygen is primary nursing intervention. All right, so much with the theory. Let's head on to the quiz section. Here is the first quiz for you. Which of the following could be nursing intervention for the patients with MI? Administer morphine. Administer supplemental oxygen. Sedate the patient. See ECG findings to help to identify MI and locate the position of MI. Well, there are 3 correct answers here. First, second, and last. I hope you got that right. Which of the following ECG reading is of myocardial infarction? Yes, you are right. You clearly see the elevated ST segment in this EKG strip, which shows myocardial infarction. There could be different types of heart blockade. It can be sinoatrial block or a V-atrioventricular block. The sinoatrial block is not easily recognizable on the EKG strip, also not very dangerous compared to other heart block. The AV or atrioventricular block could manifest in form of first-degree heart block in which there is slow conduction of impulse, or it could be intermittent failure in condition called second-degree heart blockade or third-degree heart blockade in which there is complete blockade in the conduction of the impulses. The second-degree blockade in turn is of 2 types called Type 1 or Wenckebach heart block and Type 2 or Mobitz heart block. In the first Type 2 block, there is slowing of conduction velocity progressively until there is total failure in conduction of the impulses. Mobitz Type 2 heart block is characterized by an intermittent dropped QRS that is not in a Mobitz Type 1 pattern. The causes of heart block for all these types of blocks could be myocardial infarction, or it could be a V-nodal blocking drugs such as calcium channel blockers, digoxin and beta blockers, or any idiopathic degeneration of the conducting system with diseases such as Lindgren's disease. Don't worry, you will understand all these in detail in the coming lectures. First, let's head on to first-degree heart block. Grade 1 AV block. In the grade 1 or first-degree AV block, there is delay in impulse conduction from atria to the ventricles. So there is a conduction delay in the AV node. The heart rate is below 100 beats per minute. The first-degree heart block is benign in nature. The PR interval is constant and is greater than 0.2 seconds. That means the PR interval is prolonged as compared to normal sinus rhythm. The QRS interval is greater than 0.12 seconds. Here, in this EKG strip of grade 1 of V block, we can see that the PR interval is constant but wider. Grade 2 heart block. As discussed earlier, in the grade 2 type 1 heart block, there is intermittent blockade in a V conduction, and this is also called Wenckebach phenomenon. There is a progressive increase in PR interval until a V conduction is blocked, until it is followed by a QRS complex. After some time, the PR interval returns back to normal and the cycle continues. The second-degree type 1 heart block or Wenckebach syndrome contains repeating PR interval. This type of heart block is not usually dangerous, but patient may complain of tachycardia or palpitations, difficulty in breathing, etc. The second-degree heart block is more likely to respond to atropine and has a better overall prognosis. Here in this EKG strip, we can see progressive increase in PR interval. Grade 2 type 2 heart block occurs below a V node in the bundle of His. The distinguishing sign is unlike grade 2 type 1 heart block, there is no progressive lengthening of the PR interval. Here, there could be 2 or more normal PR occurs, and then the P wave is not followed by QRS complex. This type of heart blockade often requires pacemaker placement, is less common and more serious than grade 2 type 1 AV block. Here, in this EKG strip, we can see grade 2 type 1 heart block, where we are seeing 2 normal PR, and then the P wave is not followed by QRS complex. The grade 3 AV block represents total impulse conduction failures between atria and ventricles. There is a need of placing pacemaker in this type of heart block too. Often, a third degree of V block develops due to a gradual deterioration of a second degree AV block, which may be type 1 or type 2. There can be severe bradycardia due to absence of a V conduction. Presentations in EKG strip. Regular PP interval. Regular RR interval. Lack of an apparent relationship between the P waves and QRS complexes. And more P waves are present than QRS complexes. The ECG demonstrates complete V dissociation with independent atrial and ventricular rates. This results in the P waves or atrial depolarizations being completely unrelated to the QRS complexes, ventricular depolarizations, meaning the P waves occur at one rate and the QRS complexes at another. This is termed AV dissociation. They require urgent admission for cardiac monitoring, backup temporary pacing, and usually insertion of a permanent pacemaker. In this EKG strip, we see that the P wave is multiple and few QRS complex. There is a complete dissociation or no relation between occurrence of P wave and QRS complex. Okay, so much with the theory. Let's start with the practice quiz. You are given with 4 types of heart blocks in EKG strip. Your job is to identify the type of heart block. This is grade 2 type 1 heart block. In this EKG strip, we can see progressive increase in PR interval. This is type 1 of E block. We can see that the PR interval is constant but wider. This is grade 2 type 2 heart block. We are seeing 2 normal PR and then the P wave is not followed by QRS complex. This is grade 3 heart block. P wave is multiple and few QRS complex. There is a complete dissociation or no relation between occurrence of P wave and QRS complex.